welcome to this ATS PR Assembly Journal Club. My name is Antenor, and I'm a member of the ATS Assembly Web Committee. Before I introduce the article and the panel, I just want to let you know how you can interact with us during the webinar. So we will start with the paper presentation, and we will ask questions after the presentation is finished. If you have a mic connected to your computer, you can click on the hand icon on Zoom, and then we will allow you to unmute yourself, and then you can ask your question. If you don't have a mic, or if you don't want to open your mic and talk to us, you can put your questions on the Q&A box, and I will read that. Of course, we would like the discussion to be very lively, and we would appreciate if you were willing to open your mic and ask your question yourself, so we can have a more warm interaction, let's say. The article we'll be discussing today is entitled "A Long-Term Physical Activity Coaching Program for Patients with COPD." It's RCT by Astrid Blondeel and colleagues from Leuven and Gent in Belgium, and was published in the Blue early this year, so congrats to the group. Felipe Machado, that is a postdoctoral researcher at the Hasselt University, will present the article. Unfortunately, he was not able to be here right now. He will join us later, but he kindly sent his presentation so we can watch it during the webinar. Astrid Blondeel, Heleen Demeyer, and Thierry Troosters, co-authors from the paper, are joining us today. So thanks a lot for taking the time. And our expert panel is Doctors Judith Garcia Aymerich from Barcelona, Spain, and Fabio Pitta from Londrina, Brazil. Thank you for you as well. Sairan, and that is from the Cleveland Clinic in the US, is also a member of the ATS Web Committee and is here with us helping on the organization of the podcast. And Daniel from the ATS is managing all the technical aspects in the background. So thanks a lot, Daniel, for organizing this. So now we will start with the presentation. So I'll ask Daniel to start the video from Felipe, and after the presentation, I'll get back to you, and then we can start the discussion.
Hello everybody, welcome to this new journal club enabled by the ATS and more specifically the Assembly on Pulmonary Rehabilitation. I am Felipe Machado. I'm currently working as a postdoctoral researcher at Hasselt University, and I'm going to present the paper entitled "A Long-Term Physical Activity Coaching Program for Patients with COPD, a Randomized Controlled Trial." So this paper was published by Astrid Blondeel and colleagues under the supervision of both Professors Thierry Troosters and Professor Heleen Demeyer. These authors come from 6 different departments among institutions in Belgium. So let's start with a short background. In the introduction section of this article, the authors start by showing the data and demonstrating that patients with COPD have lower levels of physical activity as compared to healthy control subjects, and also that physical activity or physical inactivity is associated with an increased risk for faster disease progression, but also exacerbations and mortality. And therefore, physical activity is recommended for all individuals with COPD, so included those with patient group A or in patient group B and E. So physical activity is recommended in all individuals with COPD. Well, in fact, several physical activity promotion strategies have been investigated in patients with COPD. Among these strategies, we also include physical activity coaching interventions. And we do see positive effects of this intervention in short term. So they are able to promote physical activity in the short term, but still long-term effects are unclear. And one explanation for these non-persistent effects is the fact that adherence decreases over time. So this is one aspect that should be improved in physical activity coaching intervention. And we should know that there are many different ways on how one could design a physical activity coaching intervention. However, we still don't know if a more complete coaching strategy with dynamic goals, regular feedback, could be more effective in the long term. For this reason, the aim of this study was to investigate the effectiveness of a fully deployed physical activity coaching intervention to improve and maintain physical activity in people with COPD in the long term. And this would be compared with a light coaching intervention that actually mimic the real-life use of consumer-based activity trackers with no supervision or with limited supervision. And the hypothesis of the authors was that this intensive with more frequently feedback telecoaching program would be better than this light version to improve but also to maintain physical activity in this population over 1 year. Now let's start to discuss the meta section of this original article, starting by the study design and population. Firstly, all study participants were recruited at 3 hospitals in Belgium between January 2020 and November 2022. These participants were randomized into 2 physical activity coaching interventions. They were all blinded, and also they repeated their measurements at 6 months and 12 months. So this makes this study a multi-center, single-blind, randomized controlled trial with a 12 months follow-up period. The inclusion criteria included being older or at least 40 years, having COPD confirmed by spirometry, having a minimal smoking history of 10 back years, and not presenting moderate or severe exacerbations in the past 4 weeks. Exclusion criteria included patients that were currently in pulmonary rehabilitation or on lung transplant waiting lists, and that were unable to use a smartphone or had musculoskeletal conditions that could affect physical activity. So let's start to explore some information about the 2 different interventions. For this, I'm going to use this great illustration prepared by the authors and also a table that I made. As you can see, the 2 groups started with an interview at baseline to discuss motivation, self-efficacy, barriers, and strategies to become more active. The difference between the 2 interventions were more regarding the goal setting, that for the full coaching group was dynamic and adapted every week, while for the light coaching group was a fixed goal based on the 6-minute walk and distance. Full coaching group had feedback daily and weekly, while the light coaching group had a graphical representation, more a neutral graph of daily step countings. And the coaching intensity was high for the full coaching group and low for the light coaching group. So it means that during the first 6 months in the full coaching group, patients also had contact by phone for lack of the step goal progress and non-compliance, while at the maintenance phase from 6 months to 12, and that was also the same for the light coaching group, phone contact was only in case of non-compliance, health problems, or technical issues. Regarding the outcomes, primary outcomes were physical activity outcomes, and physical activity was objectively measured using a Dynaport Move Monitor during waking hours for 7 consecutive days. 3 main variables were assessed as steps per day, movement intensity during walking, and walking time. As secondary outcomes, we have functional exercise capacity, quadriceps muscle force, pulmonary function, health status, health-related quality of life, and symptoms of dyspnea, anxiety, and depression. There were also exploratory outcomes including fasting blood lipids and glucose, body composition and bone density, the intervention satisfaction, exacerbation history, and adverse effects. I will provide now a brief overview of the statistical analysis. So authors used SAS and defined p-values lower than 0.05, and according to the sample size calculation they would need to include 150 subjects. The main analysis was a mixed model for repeated measures with group visit and group visit interaction, and these models were adjusted for exacerbator status, recruitment site, and duration of daylight. The authors present intention to treat but also peer protocol analysis, and no compliance for the peer protocol analysis was defined as lower than 50% of weekly reports completed or dropout. They also performed a responder analysis based on minimal clinically important difference in daily steps, and they also investigated determinants of physical activity change using linear regression and adjusting the analysis by baseline physical activity and group allocation. We will now delve into the results of the present trial, and this is the first figure showing that 150 participants were randomized in either the full coaching group with 77 participants and the light coach group with 73 participants. Over time, there were a few dropouts in both groups, but at the end of the 12 months follow-up, there were 65 patients with valid physical activity measurements in both groups. Now, regarding the baseline characteristics, we see in this first table that they were similar between the two groups, and this include age, sex, some variables for lung function and disease stages, few of the secondary outcomes, and also physical activity, which was approximately 5,500 for both groups, and also there was a similar proportion of patients that were included during different seasons. We see in this other table that about half of the subjects were classified as sedentary according to the threshold of 5 steps per day, while about 10% of the participants were considered very active. Regarding the main analysis, the authors present this. This is the second figure where we can see that in the intention to treat analysis, no difference were observed between the full and the light coaching groups in change of the amount of physical activity, that's the panel A, also the intensity of physical activity, panel B, and walking time, that's the panel C. Over 12 months. We can see that there was an initial non-significant increase, but this was followed by a decline from 6 to 12 months. For the protocol analysis, in the full coaching group, 71% of the subjects were compliant, and we can see in the figure how this affects the estimates, but still in the per protocol analysis no significant difference were found when we compare the full and light coaching groups. In the second table, the authors also present the main analysis for the secondary outcomes, so we see what happens for functional exercise capacity, quadriceps muscle force, health status, symptoms of dyspnea, anxiety and depression, and also disease-specific health-related quality of life. We see the estimates and the p-values. There were no significant p-values, which means that the interaction, and that means that the effects over time or changes over time are not different according to group allocation, but the authors do report significant and clinically important within group changes at 12 months when we analyze just the full coaching group for the dyspnea score of the CRDQ and also the scores of anxiety according to HUTS. In this third figure we see the flow of the physical activity response classification from baseline to 6 and 12 months of follow-up. for the full coaching group on our left and for the light coaching group on our right. And the flow is represented by the green color are the patients that improve it, or they had an increase of 1,000 or more steps, while in the pink color we see those patients classified as decreased, also by a reduction of 1,000 steps or more, and between them we see those patients classified as stable, and these are those with positive or negative changes that are less than 1,000. We also see the flow to demonstrate those with missing physical activity data in the light blue color below. And this makes us easy to see the responder analysis, and we could see that from baseline to 12 months, 19% of the patients in the full coaching group improved, while in the light coaching group this number was 22. The authors also provide this fourth figure with the change in step per day, but then according with the activity tracker. That's why we have more time points and not only 3 as we had for the Dynaport Move Monitor. And we see that at the beginning there was an initial response that tended to be larger in the full coaching group, that's the green solid line, as compared with the light coaching group, the dashed green line. But we see also that after 12 weeks this difference disappeared, and also we see that the progression until the end of the study was similar when comparing both groups. Now, what about the determinants of physical activity change? To display these results, the authors present this table in the online supplement where we can see the regression analysis of change in physical activity and their predictors or associated factors. Among the physiological factors that are significantly associated with change in physical activity, we see symptoms of dyspnea assessed by the MMRC, and also a health status assessed by the CAT questionnaire. Among the psychological factors, we see that symptoms of fatigue were associated with change in physical activity from baseline to 12 months, but also difficult with physical activity. And among the factors related to the follow-up, there were also 2 variables that were significantly associated with change in physical activity, and these are the percentage of days with a step goal achieved, and also the change in a 6-minute walking distance. Presented the main results, the main findings of this manuscript, but the manuscript is comprehensive, so there are more analysis and findings that for the sake of time I could not show. But in general, the authors could not confirm the initial hypothesis that the full coaching intervention would be more effective than the light coaching intervention to maintain physical activity over time. They indeed show that the annual decline in physical activity that was reported in patients with COPD, it's larger as compared to this study, and they provide some possible explanations for the study findings. The first was that the telephone contact with the coach to discuss the goals and motivations was not so intense during the second half of the study, so during the maintenance phase in the full coaching group intervention. The second one is that this full telephone contact was needs driven, which means that it was started by the coach only in those patients that had difficult to reach the step goal. So the patients that were more adherent, they just had the regular, the basic feedback and not the contact with the coach. So this maybe it was also a factor that could explain the findings. The third factor is that they were using an updated coaching app, and they had before an earlier version and then they demonstrated the effectiveness of using the earlier version over 6 months, but that was not the case now. And in this updated coaching app, it was more automated. So they increased the automation, and consequently this reduces the amount of mandatory or compulsory interaction that the participant will have with the app. So maybe this update may have lowered the effectiveness. Well, the fourth factor is the patient selection, and I did not have time here to show the subgroup analysis, but actually subgroup benefit from the intervention. So there are sustained effects observed in those who comply to the intervention. So both interventions are effective in a specific subgroup, so maybe you need to find the right patient to perform this kind of intervention. And the last is the Fitbit monitoring, because when the data was analyzed using the Fitbit, this shows a more continuous monitoring of the outcome, physical activity, than when we select or when we use just the cross-sectional or the week that were assessed using the Dynaport Move Monitor. So this might indicate that we need not only to measure it during that week, but we need a continuous measurement if we need to, if we want to detect changes. The authors also explain the strengths and limitations of this study, and the strengths include the fact that participants were blinded, also the fact that physical activity data was collected according to the most recent international consensus, so state-of-the-art physical activity measurements, and that the authors also included patient-reported outcome measurements. I also did not have a lot of time to explore here, but for example, the experienced difficulty and the amount of physical activity self-reported by the patient, so what does the patient receive as change in physical activity. And the limitations include that there is a small proportion of participants in the streams of the growth stages. There might be also some selection bias because by design the patients that are more motivated would be open to start and to continue in the study. And last is that this study was conducted during the COVID-19 pandemic, so we do not know for sure what was the impact or the influence of the pandemic, but for sure this might be a problem. In conclusion, no additional benefit of a fully deployed telecoaching intervention was observed in comparison with the light telecoaching intervention on changes in physical activity at 1 year follow-up. So the addition of these other elements such as the dynamic goal setting, daily and weekly feedback, regular contact with a coach through a smartphone app did not enhance, or we could not see any additional benefits of these new elements into telecoaching intervention. So I made this presentation to provide a basis for our discussion. I hope I will be able to join soon to further discuss this RCT. I need to declare that the icons used in this presentation were retained from flat icon, and for now I would like to thank you very much for your attention.
Okay, so thanks, Felipe. He's not here yet, but hopefully will be joining us soon. So let's move to the discussion part of the webinar. So just to remember everyone, if you have a question, you can raise your hand, and then we will allow you to unmute yourself and ask your question to the authors and the panel. If you prefer to type your question on the Q&A box, then I will read it out. So just to start, I suggest we move forward first to Judith to ask a question, and then to Fabio, and then we go to the attendees if they have any questions, if that's okay to everyone. So thanks a lot again. And Judith, I will let you ask your question now. Thank you.
Thank you. Well, good morning, good afternoon, everybody, and thank you for inviting me to discuss this paper. I first want to congratulate the authors for the paper and basically for the study. It looks very interesting, and what I found amazing is that you basically have no loss to follow-up. That's really commendable for a 12 months follow-up, and also it was in COVID period. So really congratulations for that. I do not have questions, let's say. I have some comments that may help us understand what works, what doesn't work, and how we change behavior. So my first comment is about the intervention. According to the most recent literature, let's say on behavioral change, we have learned that to change a behavior requires different intervention tools than to keep the behavior stable. So we need to do something to make that these patients start walking or moving. And then what we need to do to keep them in this action is something different. So my question to you would be if you considered differences in the intervention between the first part or once the patients had changed the behavior or before and after that. And if you didn't, whether you think this would have affected something or if you would do this differently. And then also in relation to the intervention, you know that in our experience in the urban training intervention, what we found most interesting, according also to the patients and the detailed evaluation, is that the intervention was closely linked to social factors, the socio-environmental factors. And then my second question in relation to the intervention is whether you took advantage of the social environment of the patients, whether you used them to facilitate their changes in behavior and so on. Thank you.
Okay, thank you, Judith, for these questions. I think I will start, and Heleen and Thierry can, of course, add. Regarding your first question, you're totally right that we first need to change physical activity and then try to maintain it. And in our study design, we try to mimic that by, in the first 6 months of the study, we really, in the full coaching group, we really called the patients a lot to discuss if the goal was not increased or if they could not maintain the goal. Then we call them to, force them a bit or motivate them as much as possible. And then in the second phase, which was for us like the maintenance phase, which was the second 6 months, we only called them when there were technical issues or health issues or these things, and not anymore these calls regarding the goal setting and regarding further improving the goal. So that was a bit our idea. Like in the beginning, we need to grab the patient and really motivate them as much as possible if things are going sideways. And we, once they are in the maintenance phase, we can stop that. But looking at the data now, maybe this was not the best strategy to have these long-term effects. But because, maybe by not calling them anymore as often in the second phase of the study, we lost them a bit. So, it is a difficult one to say what is actually needed to improve, but also maintain, especially when we look at long term. Maybe we don't need to loosen up on these patients. We need to keep in touch with them. So that's what we see in the data now, that maybe we should have called more often. And also, we only called patients when things were going sideways, but maybe we should also call patients when things are going well. Now, when people were compliant and they met their goal every week and they were improving by themselves, we didn't call them because we were like, okay, they're doing fine. We don't need to push them. But maybe it's more motivating for patients that also these patients have receive a phone call from the coach to saying that they're doing a good job. So it is very difficult to see which strategy is actually the best, as behavior is very complex entity. I think. I don't know, Heleen and Thierry, if you want to add up on that.
Maybe if one thing I would do differently, I think, is work a bit more with our action plan, because in the motivational interview, we made an action plan with patients and we really developed together with them concrete actions to include activities in their daily life. So they came up with the ideas and we discussed them. And I think, yeah, it might, well, during the coaching calls, these were discussed if things were not going very well. But I think maybe in the maintenance phase, this should also be something that we need to reflect again on, like these behaviors that you thought you would change. Where have they been changed? And is this a change that you can maintain? So maybe some concrete actions would have been interesting to, yeah, still follow up on in the follow-up period.
Yeah, I think if I may, what we did differently from the urban training study, Judith, I think, is that we didn't have a formal prescription of exercise. So we had basically a volume prescription. We let patients walk, but the intensity was not controlled. I think in your urban trail study, you also had different intensities or different gradations of difficulty, I think, in the prescribed walking areas where people could go. And I think that might also have been of benefit. I mean, it's just slightly more prescriptive on what people could do. Another example would be the Kaya app that Rainer Glöckel has worked with, where also some predetermined exercises were included. And so that also may help people to sort of stay on track, particularly if they experience an exacerbation. I think that's one of the caveats of our program, is that we want the patients to feel success. And so when things were not working out well, we were sort of lenient with them. We said, yeah, okay, this has been a difficult week. Do you want to reduce your steps? And all of a sudden, steps could be going down a lot through the algorithm, and then slowly perhaps build up again, but still at much lower levels than what they ever were before. So that's a loophole, I think, in the algorithm that we use to coach the patients, and there perhaps we could have also done differently. But I think the prescription of exercise may have been a crucial flaw if you look at it from hindsight.
Thank you.
Fabio?
Hello, everyone. Can you hear me well? Yep. My connection was a bit unstable, but I think it's back to business now. Hello, everyone. It's a real pleasure to be here with so many colleagues that I admire, and also so many professionals that are interested in advancing in the field of improving physical activity in chronic respiratory diseases. It's an honor to be here. To be honest, just to start, I remember the time when our main concern, our main worry, was not necessarily if a full coaching program was better than a light coaching program, but if coaching of any type is better than no coaching at all. I remember that time when we were discussing that in the literature, at least in the short term. And since we know now for sure that this has been clearly shown, we're now safe in this territory, and we're now advancing in more recent years to fine-tune the programs and to find the best design, and also studying and understanding better the long terms, and exactly what these authors have done. So congrats to the authors, to the group on your study. Well done. You provided us with a lot of useful and novel information that we can use on this matter. And my first question is a bit of a brainstorm about the composition of the light coaching program to the group. The light coaching program involved an activity tracker plus a step goal, which was fixed, I understand, was not dynamic, but okay, was still a step goal. And plus some contact with the patient. And now in retrospective, looking back, do you think that this intervention would really qualify as a light intervention? Because from some perspective, it doesn't look so light, because it involves important elements of coaching in a certain intensity. So I believe that many people would not necessarily classify this intervention as light. Could you provide us your thoughts on this?
Yes, thank you very much, Fabio, for this question. It's a very good question, and we discussed this a lot within the team. That's for sure. And I think we can discuss about this definition. But when we were designing the study, so maybe I can explain a bit more from where it comes from. When we were designing the study, we wanted a group that mimics the real life use of a consumer-based wearable with a consumer-based application with limited contact with a coach, and try to keep it as minimal as possible. But I agree, when we look now at our study, we now realize that we did more than we did lots to the patients, that we did more to patients than we were actually expecting, because by giving them not only the Fitbit, but also a step goal, and also these patients really felt that they were followed up by us. Although for us it felt quite light, we didn't call them that much, only when there were problems. But for them, it really felt like they were followed up. They were being watched. Their physical activity levels were watched by us. So for them, it felt like an intervention. Yeah, we can discuss about if this is light or not. Our primary idea was that this was a sham intervention, which we definitely in retrospect changed to light, because this is definitely not sham for patients. And so yeah, I think we can call it a light compared to what the other group received. But it's definitely not nothing. That's true. But from the perspective of a healthcare provider, I think we can still call this as light, because we don't call the patients that often. We don't see them that often. So yeah, that's maybe why we chose this kind of wording. Yeah.
Yeah, we definitely didn't want to provide nothing to people, and there were several reasons for it. First, the methodological reason was that doing nothing would not be fair to those that received the intervention. So a sham intervention that perhaps was a bit more elaborate than we wanted to was needed. Secondly, we also wanted to have the steps in these people, because in 2020 or 2019, when we were designing this study, we thought that if we would be able to change physical activity, we would be able to change the course of the disease. And so we wanted physical activity in as many patients as possible. So that's why we gave everyone a Fitbit to see if changes in physical activity also in the control group would lead to better health outcomes. In hindsight, probably a year was not long enough. And the impact of changing physical activity within a reasonable margin, let's say 1,000 steps or 1,500 steps, may not have that big an impact on the health over a period of 1 year. But when designing the study, we wanted to have physical activity objectively measured with a tracer, with a tracker in as many people as possible, hence also in the control group, because it amplified the number of available patient data. I don't know, Heleen, whether it's fair to say that was sort of the inside kitchen of the design of the study.
Yeah, no, I don't have much to add. Maybe just that, this is a follow-up of our first study, which was the full coaching study as compared to usual care for 3 months, as part of the Proactive project. And there it was actually one of the reviewers of the article that asked, but this is a multi-component intervention, and how sure are you that all these components are needed? And this is why we wanted to compare it not to usual care, but to a light version, showing, well, the hypothesis was that we could show that the multi-component intervention was needed, but the results showed us some different results.
Okay, thanks. So I will move to Sayuan. You have a question as well, right?
Yes, thank you, Antenor. Thank you all for this wonderful talk. It's been truly an honor listening to this, and it's a well-executed study with very, very little loss to follow-up as well, as it was done in the COVID-19 pandemic, which makes it great. My question is, do you think it's based on the results of this study, it would make sense to look at similar long-term outcomes for an in-person coaching versus patients themselves using their own Fitbits for tracking? Because I'd be curious to see if that real in-person contact compared to patient dictated Fitbit activity would actually have beneficial outcomes at 12 months. Thank you.
So with inpatient coaching, what do you mean, like pulmonary rehabilitation or?
Similar, but like pulmonary rehabilitation, and with again some more specific sort of activity monitored outcomes like strength training and exercise and so on, trying to look at specific differences between those.
Yeah, I think we now in this physical activity coaching program, we mainly focused on amount of physical activity, and changing behavior in daily life. That's why we chose to work with a step counter, with patients who were at home in their own environment and doing it remotely via the smartphone application. We did not say anything about intensity or about strength specific exercise prescriptions or stuff, because this was not the aim of our study. We were really looking at physical activity behavior. Yeah, I think these are two different fields, and that we that we should let's also ask for a totally different approach, I guess.
No, understood. Yeah, thank you.
And I'm not sure, Saram, if you perhaps meant, do we wanted to see the patients more face-to-face and invite them for a face-to-face coaching program? I really think that probably the telecoaching is a good approach in those patients that pick it up. I'm not sure that seeing the patients face-to-face actually will contribute a lot. We did that a long time ago in a study where we introduced face-to-face coaching during an exercise training program, and actually it didn't really have big effects. So I think actually patients are now up to speed with their mobile phones, and they can use this as a way to improve physical activity in that fraction of patients who pick it up.
Okay, thanks. I will go. So we don't have questions from the audience yet. So please, again, raise your hand. I apologize if I'm missing it, or put your question on the QA box and I'll ask it. But I'll move now back to Fabio for his next question.
Okay, Antenor, thanks. For the second question, Astrid, I would like to come back to the good old relationship between exercise capacity and physical activity, and explore a bit one nice result that you got there, interesting result, which is the fact that despite the expected little changes in exercise capacity after the protocol, because after all, you didn't perform exercise training, right? So you didn't expect them to happen. Despite that, your regression analysis showed that improvements in exercise capacity at 12 months were positively associated with changes in physical activity. So does this mean that an associated training program would be useful, an useful addition to the protocol? What I mean is, the more you gain exercise capacity, the more useful would the coaching program be? What do you think about that?
Yeah, that's a very good question. We indeed saw, when we look at the determinants of success, that change in exercise capacity was one of the significant factors. And I think this totally fits within the idea that we need some exercise capacity to be able to perform physical activity, so that patients who are very weak, we don't need to start with physical activity. These first need to build on their exercise capacity, and then in the second phase, we can work on physical activity and change behavior in their daily life. So I think this fits a bit within this interplay, and also it's in line with the other determinants that came out, that we saw that patients who are highly symptomatic, have a high MMRC score, a lot of fatigue, that these were not the ones who were improving with the coaching intervention. So on the whole, I think we need to focus. It's still difficult to say exactly which patients are the best candidates, but it seems that patients with a better exercise capacity, patients with less symptoms, that these are the ones that we can offer such a kind of intervention, and that in patients with who are more symptomatic, have low exercise capacity, we first need to perform go look at exercise training and pulmonary rehabilitation. Yeah, I think, yeah.
Yeah, if I maybe add, I completely agree, of course, Astrid. If we make it easier for patients, then it will be easier to make the active choice. So it's in line with our hypothesis. So the better exercise capacity, the less symptoms, then patients will be more likely to take up these interventions. I think if it's easier to take the active option, patients will hopefully be more likely to take that active option.
Yes.
Okay, so just before I move to Judith, we have a question on the Q&A from Dr. Kazaburi. So I'll ask it. He says, I would maintain 6-minute walking test as a measure of exercise performance, not exercise capacity. It is therefore not surprising that those who improved physical activity in everyday life also improved 6-minute walking distance. You have a comment, a question for the authors now?
First of all, hi, Rich. Good to see you in the call. What a pleasure. I think you're right. Overall, we have to see this in the context of a declining group, a group that declines in exercise capacity. So it's less decline, actually. It's not necessarily an improvement, but less rapid decline. I think that's maybe the thing I wanted to add to the previous discussion and to your question. But yeah, I mean, we're not native English-speaking people, so capacity, performance, I mean, tolerance, there are different words, and the one you choose is the right one.
Okay, Judith?
Yeah, thank you. It's good because my next comment was about exercise capacity or performance, well, as well. So your group was actually the first started saying, we first need to train the patients, they need to have the proper capacity, and then we modify their behavior, right? And you have this wonderful figure that all of us use for teaching. So I was surprised that you didn't have any inclusion criteria related to the level of capacity. So I wonder, why didn't you ask or recruited only participants who had higher capacity and lower activity? Because those with lower capacity, actually, on average, they are more or less okay, but there are some that have lower levels. So they wouldn't be able to modify their behavior even if they wanted. And others were actually on a more than okay level of physical activity. So maybe they shouldn't have received the intervention. And well, I'm asking this, and these are kind of mistakes that we did in the urban training as well. But then you learn how maybe next time you need to select the patients a bit differently. So would you reconsider this?
Well, no. So why we chose this approach and was to because yeah, our main question was like, what is the best strategy to coach patients, and also look at these determinants. So that's why we wanted a broad sample of patients to really be able to see, like, okay, when people are in the better spectrum of exercise capacity or and in the lower spectrum of physical activity, these are the ones that have a better response to this intervention or not. If we would in the beginning already put it more strict and only focus on this group, maybe we could not have found these or answered our question on determinants of success and determinants of change in physical activity. So to be able to answer this question, that's why we kept a broad spectrum of patients with COPD. As was also highlighted by Felipe, actually we wanted to have an even better that all groups, all levels of COPD were equally available in our sample, which was not the case. Like the gold 1s and the gold 4s were less represented in our sample, which was a bit of pity. But okay, that's a selection bias we have. But I think it is interesting that we try to keep it as broad as possible, and maybe in next phase, when we really go for specific patient selection and see if this intervention works in a specific patient group, that would be my next step, but not my first step. But I don't know if Thierry and Heleen agree with that.
Yes, I think that's a really fair point, Judith. But maybe in the proactive study, so the short-term coaching study, the effect size was higher in those with a good exercise capacity, but it was still around average, a bit less than 1,000 steps for those with a low capacity, but it was 2,000 steps for those with a high capacity. So it's more difficult to coach patients with an impaired exercise performance, but it's still possible. And I don't think we knew this at the long term. So maybe in 1 year, if we could also in those with a limited capacity maintain their physical activity with these programs, that would also be a valuable result of this study. So therefore we chose a very wide spectrum, but I think it's a fair point that maybe in hindsight, the effect size would have been higher if we would only recruit the better patients.
But I'm not sure that the difference between the two groups would have been much bigger. I think maybe these better patients would have also responded to the what we first called a sham and now a light intervention. I think also on the average, the group is not. I mean, it's relatively well preserved in terms of 6-minute walk. It's 470 meters or so. So it's on the average above the threshold that Heleen used in the original proactive study. So these were not really the worst patients, but they had a broad spectrum. I fully agree with what Astrid said on that, and that was purposely done because we also wanted these bad patients to see if we would be able to increase their physical activity just a little bit, whether that would have felt benefits in the long run.
Okay, so we moving now to the last 5 minutes of the webinar. So what I'll do is I'll do a last round, open the mic to both of the panelists if they have a last question or a last message, comment for the authors, or where they think the field is moving now after this last publication. So I will, just to finish the last minute, start with Fabio, then Judith, and to like the last bit, I'll let the authors give their message or their summary or any direction they want to share with us. Okay, Fabio, that's up to you.
Thank you. Very short one. Astrid, how was the use of home oxygen dealt with in the study? Did you consider it as a relevant factor in the results, or how did you deal with that in the results?
Yeah, we there were only a very limited group of patients who used home oxygen because we didn't have a lot of very severe patients in our sample, but I cannot recall the number by heart, but it was very limited. So that's why we could not use this in the analysis as a factor. So we didn't look at the effect of use of home oxygen. But it was definitely not an exclusion criteria or something. There were some patients who were on oxygen, but we didn't use this in the analysis.
Yeah, it could be a factor in the results if there were more severe patients, as I understand the sample now. So we can only speculate. Yeah, thank you very much.
Thank you.
So my comment is like more general in the field. I think we are a bit maybe contaminated by drug clinical trials. And this whole comment, and it was also mentioned by Felipe, that this selection bias, I do not see this as a problem. I do not see this as a selection bias. So we know that behavior is complex, and there is no reason to believe that all the patients with COPD will behave the same way. So there is reason to believe that their bodies will metabolically respond the same way to a drug, but not to a behavioral intervention. Therefore, I think we shouldn't be trying to design interventions that work for everybody because we want everybody to respond to the same intervention. Maybe it would make more sense that we understand better the behavior, we perform more respondents analysis as you actually did, and then we design different types of interventions for different type of patients, because actually we want this at the end to be bought by the health services, right? And we know no intervention is going to be effective. No behavioral intervention is going to be effective for everybody the same. So I wonder whether you agree with this. That's more a personal comment after my experience in the field, but what do you think?
Yeah, I fully agree. That's also a bit what I learned from this study. When I started my PhD and I started the study, you really focus on the between group differences and these things. But I think looking at it now, we tested two different kind of interventions, and when we see the responder analysis, these are similar for both interventions. And I think some patients, and also when I'm looking at the patients who were coached, some patients were very happy with the light coaching intervention, and for them this is enough and they are doing very well with it. And some patients need a full coaching intervention, and some patients will need something else. So I think that this is the main thing I learned from this study, that it's not a one size fits all, and we should not only look at the between group differences. Of course, we need to look at this, but there's more in this story, I guess, and we need to look at what the patient needs, and it's very difficult to throw this into responder analysis and determinants and stuff. But I think, when we are looking at clinical work, maybe we should try and see, is this patient good with a light coaching intervention, or does he need something else? And then step up or change the intervention depending on what the patient needs. So I fully agree with you.
Yeah, I also agree with that, and it's definitely something we learned from the trial. It's also something you learn when raising children. You need to have a plan B if plan A doesn't work to change behavior. And that's exactly the case in patients too. If you go to Michi's taxonomy on interventions that you can use, there's 92 different things that you can do to change behavior. And here we tried just a handful of things. So I think it's really important that we know this as a science. It's a bit like exercise training. In some patients, interval training may work super well, and in other patients, resistance training will do better, and in other patients, endurance training will do better. And it's a bit the same with behavior change programs. So you need to know these different techniques, and if something doesn't work, then try something else. Just like what you would do with smoking cessation, which is also behavior change. So if something doesn't work, try something else. I think that's indeed, as Astrid said, that's something I've learned perhaps the hard way from this trial.
Okay, so I think we got to the end of the webinar today. Again, I would like to thank a lot everyone that was here to hear the discussion, but especially to the authors and the panelists that took the time to help us and prepare the discussion and prepare the presentation and prepare the questions and everything. So thanks a lot, Astrid, Heleen, Thierry, Judith, and Fabio, as well to Saidam and Daniel that were here to support the organization. We don't have yet the date for the next webinar. When we do, we will share with everyone online in our pages. So keep following us on LinkedIn, Twitter, or whatever you like the best. And hopefully see you on the next ATS webinar very soon. Thanks a lot, everyone, and bye-bye. Have a nice day, evening, night, whatever you are there. Bye-bye.